Hi everyone, welcome to your second lecture of biomechanics, and we're going to focus on anatomy and anatomy fundamentals. Essentially for the course, you won't need to have everything memorized in super detail. Being familiar with them, recognizing, if it was to come up on a question asking you like, the biceps are flexing the arm, what is the forces involved, you'd want to be able to know what the biceps are, what flexion is, what that entails. So that's the level of detail that you'll want to have it known for. You won't be expected to like memorize spelling and stuff like that. Okay. But yeah, some of you have already might have taken your anatomy classes, which will just make you that much more familiar with these. Okay. But yeah, so to get started, I was like taking a look at this and just remembering that anatomy and physiology, our understanding of physiology has changed a lot, but the anatomy itself really hasn't changed in hundreds of years. This is a really famous painting by Rembrandt, and it's about an anatomy class. So these were all people training to become physicians, and again, not much has changed, and even then there was a level of standardization in the language that they used to describe the human body and its orientation and directions. And the reason for that is if you can think of all of these people around this cadaver, and they're trying to explain, directions to one another. So these gentlemen down here, say, move to the right, or go farther up or down. Those orientations, so up and down and left and right, are going to be very different from their perspective relative to these gentlemen up here. So what's been done is the standardization of language and terms as far as directionality and anatomy, so that regardless of literally where you are relative to, say, a patient or a client, or in the world, there's this level of understanding for communication between practitioners. Okay, so that's exactly what it is, and why we go through all these terms and have these names for things. So to start us off, we want to look at anatomical position. And we see the Vitruvian Man, again, another classic piece of art by Leonardo da Vinci. And ultimately what it is palms faced forward, down by the side, feet turned forward and facing in square. And that's anatomical position. So every movement or directionality, names, it all stems from this. Okay, so this being the front or the anterior, and then the back being the posterior. Okay. So as far as directionality, what did I mean by that? I've said that a few times now. Well, we can essentially use certain words to describe directions on our bodies. So we'll just go through them. They're color-coded for us, so we can do that in a particular order. But if we were to look at this figure here, we can say that that person's facing towards us, so that's an anterior view. But we can start choosing landmarks on the body and then say aspects are in different orientations to them. So for example, from the knee here, the hip, so this part, is proximal relative to the foot. Okay, so we'd say the foot is distal to the knee, meanwhile the hip is proximal. So we're just proximal is just a word saying closer to the midline or closer to the center, and distal is saying it's more distant or farther away. Okay, very similar, but not to do with limbs, but more so the torso, is we have a lateral view, so off to the side, and a medial aspect. So if I was to use that, I would say, if I'm looking at my midline here, I would say the outer part of my rib cage is more lateral relative to my sternum, which is more medial. Okay, And again, if you have trouble syncing, remembering what's lateral or medial. Medial is like middle, and lateral is, if you know in football, it's kind of when you throw the ball off to the side. That's the lateral, okay? The last two would be superior and inferior. Now, that doesn't mean things lower down on your body are less important or lesser in quality or goodness. It's just inferior. And superior, super means up or above, so means high up, okay? Great. The next two here we have cephalic and caudal. And so if you're thinking about your head, if you've ever heard of encephalitis or something like that, it's an infection of the brain. So cephal is being head. It's the root word for that. And then caudal is tail. So you can think of your tailbone. And that's generally directional to your torso. And then I've already said anterior a few times, and I mentioned posterior. So that's essentially just seeing front or more forward plane, and then posterior is back. So sometimes you'll hear in, say, workout videos or something like that on YouTube where people are talking about working your posterior chain when you're doing deadlifts, and really all that's saying is the musculature along your back, your glutes, your hamstrings, so the back side of your body, or the posterior or dorsal side of your body is getting more work. Okay, so it's good to actually try to figure that out. Pick certain aspects on your own body, quiz yourself, be like, okay, relative to this, this is more distal, this would be more proximal, this is more medial, that's more lateral, and just kind of go through all the different directions to get used to that terminology. And the more you can use that just when you're trying to describe directionality on your body, it'll just become more ingrained and more natural. Okay. There's a lot of repetition here, so I'm not going to cover too much, but the one thing I did want to show you is occasionally we divide the body into planes. So this becomes more important if we're looking at, say, like CTs or imaging that can put the body into certain slices along these different planes, and that helps us orient ourselves. Okay, so if you look at the coronal, it cuts through the body this way. Okay, and one way you can think of that is coronal is kind of like crown. So if you think of a crown, you put it on, from both sides of your head, so two hands, and they kind of chop your body that way. So coronal plane. Sagittal, this goes right down the center line, center of your body that way. And so it kind of cuts you in slices if you were to walk into a blade or something vertically standing. And then transverse is across the body. Okay, so if you were to put like your hands on your hips and cut through your body that way, that would be your transverse plane. And here's kind of a look, again, if we were to look at that transverse plane. So we move up to the thigh, we chop it in half. I like to usually let people try to guess what part of the body this is first, but I'll tell you it's the thigh. And from here, so again, that's that transverse plane is cut right through, straight through the thighs that way. We can see that if we're talking about something really, really inside of us, we say that's a deep. Okay, so the very, very center of our body is very deep, whereas our skin is superficial. And you might have heard that term before as superficial wound, which just means it's very surface. Okay? Great. So that's kind of speaking to directionality and standardization of terms in regards to position as on our bodies as far as coordinate system. And now we'll touch base on our skeletal system, okay? And again, you don't need to know everything per detailed, but if you're to see these terms, see these components of the skeletal system, hopefully you'd be able to recognize them. And if you can use them in language, that's all the much better, right? Okay, so here's the axial skeleton. Axial is your skull, rib cage, and spine. Just that component there. If you look at it, you're essentially, you can almost picture just holding the spine as like an axe, and that's one way I kind of remembered it. So it's just that center skeletal aspect. And when we look at your appendicular, you can think of appendages, so your arms, your legs. It's essentially the other components of your skeletal system. And that's kind of the two different aspects or groupings of our skeletal system. Okay. So if we were to look at the axial, it's the centermost part, or we could say medial, the most medial part. And yeah, it really helps kind of house a lot of our main components of our central nervous system. That's kind of its main protective mechanism, but obviously the lungs as well for the ribs. Okay. Here's our appendicular skeletal system. Again, append is appendage. It's like our appendages, and that includes everything, including the shoulder blade or the scapula, and the collarbone or the clavicle, and our pelvis bone as well. So don't forget those if that comes up. So what I'll do, you can, again, obviously at home, hit pause here, take a moment, maybe do some Googling, because it is a really good exercise to go through and try to landmark all these bony projections that we can see from the surface of our body. Okay, so superficially, you can actually see all these different aspects or parts of the bones that stick out or project through kind of at our surface of our skin. Okay, so again, go ahead, hit pause now, and then come back and I'll do a quick run through of these for you. Okay. Good. Hopefully that went okay. If you didn't get all of them, that's fine. Right, so I'll go through, I'll kind of have a separate demo component here, so hopefully I'll pull in another video of me pointing out all these parts, but I'll just kind of quickly run through them. So the scapula, that's your shoulder blade, the inferior angle and the acromion. The inferior angle is the part that kind of sticks out at the bottom of the triangle. That's the scapula. And the acromion, or the acromial process, is up here. So the shoulder blade is kind of like a flat triangle with a little hook arm up on the top, and that's up over here. Okay. Our humerus, well, that's the upper arm bone. The epicondyles are the parts that stick out on either side of the elbow. So if you're to poke kind of on the outside and feel around, you kind of slide your hand down. As soon as it hits two bony projections, that's your epicondyles. Okay. Your radius, remember, the way I remember this is the radius is great, and it radiates around the ulna. Now that's not the true motion, but it's the more lateral forearm bone, and then your more medial one is the ulna. And now on the ulna, all the way back up to your elbow, it has this kind of like scoop-like projection that comes off the end, and that's the part that articulates around your humerus. Okay, so it kind of slides like a scooper around the elbow joint, and that's how we bend at the elbow. And then the clavicle, of course, is your collarbone. And fun fact, it's actually one of the most commonly broken bone in the human body. It's fairly common to break when you're younger, and more so when you're older. And the reason for that is we have this reflex when we fall to want to put our arms out and catch ourselves when we go to fall. So what ends up happening is you have a full outstretched hand, or if you make an acronym of that, a foosh, and you fall, you get a large impact, it goes up through the arm, and you break your clavicle. Okay. Yeah, so oftentimes you'll see on x-rays as well, because elderly people tend to fall quite a bit, and the lighter you all are, generally speaking, the less bone density you have. So what ends up happening is smaller, older women tend to see more breaks of bones than other populations or other demographics. So what you'll see is a LOL, foosh, and so that means a little old lady with a foosh, and that describes the mechanism of a break. So if you ever see that on an x-ray or something like that, that's what that means. Okay. So moving forward onto the trunk, cervical spine, that's up here in your neck. How many vertebrae do you have? Well, you have 7. okay, for cervical spine. And so that goes from your skull all the way to, and you can actually feel it if you touch the top part of your back and the lower part of your neck. There's one bone in particular that sits way out, and so that's C7, or cervical spine 7, and you can feel that one the most. So anything above that, cervical spine, anything below is your thoracic. Okay, and how many vertebrae do you have? Well, you have 12 thoracic vertebrae, and you can remember that because it parallels how many ribs you have. Okay, and of course that those two are similarly placed on the body. Okay. Then we have our lumbar spine, the last vertebrae set, and we have 5 of those. So we have fewer, but as far as distance or the amount of the torso that they cover, it's almost the same as thoracic. Why? Well, they're just much larger bones. Okay. And last but not least, the sternum. That's right here in the middle. It's a very flat bone where all the rib cage comes around and meets to. Okay. Lower extremity, you have your ilium. So ilium is the top part of the pelvis. So the iliac crest, if you put your hands right on the top of your hip bones and just kind of slide down on top, they're on either side. The lateral aspects, really top lateral aspects of your pelvis or your hips, where you can feel bone. Okay. Now, these two are fairly important. If you go to the anterior superior iliac spine, or people will say ASIS, the description kind of tells you where to find it. So anterior is, of course, forward. Superior is top. So when we're looking at the iliac spine, so the part or the crest where you have your fingers on the top part of the ilium, we can go to the most forward part and the most top part. So right at the front top part of your hips, you notice they kind of stick out a little bit. So it curves at the top and then sticks out. There's a little notch. That's your ASIS. Okay. The other part is the PSIS, so posterior superior iliac spine. And that is on the opposite end. So again, if you're on the top and you go all the way to the back, middle, top, you'll almost feel a bit of an indent there. So it's more the indent, not the projection, that you'll feel for your PSIS. Some people, you can actually just visibly see where it is. So if you've ever heard of back dimples, that's what that is. Okay, so the PSIS, or posterior superior iliac spine, is where back dimples are. Okay. We have our femur. That's the upper part of our leg bone. Okay, and there's condyles there. So if you kind of look at the wording here, there's the epicondyles, so upper condyles, and then condyles. So very similar to your humerus. If you slid down your femur and go close to your more distal from your body, and on the medial and lateral aspect of your thigh, right just before you hit your knee, there'll be 2 bony projections, okay, on the sides. Those are your condyles. Your patella, well, that's your kneecap. And so that you should definitely be able to feel. It's just a flat little, again, bit of a triangular bone that's held in place. It kind of floats, but it's held in place by tendons. So on either side of your leg, a ligament and a tendon, there's kind of these straps that help pull down the kneecap. Okay. The tibia, well, that's the thing you ding when you walk around the house and you hit something on furniture. Very painful. It's the most forward part of your shin bones and your lower leg. And the fibula is on the lateral aspect. So it's a little trickier to feel. You kind of have to dig in there pretty good. But one of the easier places to feel is actually if you go proximal, so very close to the knee, so upward up the shin, and you feel laterally up near the knee. So it's not higher up where you're touching the condyle, but it's more inferior or more distal to the condyles. On the lateral part of your leg, you'll feel something. So that most bony projection there, that's the top part of your fibula. Okay. So yeah, we've had a little run through there of bony projections. Hopefully you've been able to palpate, so feel them on yourself, and or if you have someone kicking around your home as well, it's good to just pinpoint where all those are, again, to become familiar with how to locate these things and where they're located on the body. Okay. So that's the bones themselves, but obviously we need to move. And so our skeletal system isn't a rigid component or system of our body. We have joints. So with the joints of our body, again, you don't need to memorize these. Recognizing some of the differences is important. But we have three-ish kind of different joints in our bodies, and they're classified in slightly different ways, okay? So there's a structural and a functional classification for a lot of these joints, okay? Do you need to know that? Not exactly, but if you've seen these terms, they should be fairly familiar. So we have fibrous joints, which can be synarthritic and amphiarthritic. So that's just very little to no moving and some moving. So amphi, kind of maybe like some, you can think of that. And we have cartilaginous joints that are also synarthrotic and amphiarthrotic. So again, meaning some but not a lot of movement. And your classic fibrous synarthrotic joint is in your skull. So your skull actually has joints in it, but it's so firmly held together it obviously doesn't move very much as adults. When we're younger, there's still cartilage there, and so over time as we grow, our skulls form and hold shape better. That's why babies sometimes have like cone heads right after birth. It's because their skulls aren't fully formed. Okay. Our classic cartilaginous amphiarthritic joint would be something like our vertebrae. So we have these little intervertebral discs that are very hard gels. So gel, not like liquidy gel, but like a squish, like silicone pads. So if you ever have the silicone protecting cases and stuff, it's like that, but really thick. So it doesn't really move much, but it allows a lot of cushioning. Okay. Again, do you have to memorize those terms? No. If you're to see it in a multiple choice, maybe know what they're about. But the one thing you definitely want to know for sure is synovial joints. And we'll come back to this much later in the semester, but definitely the majority of joints that we speak about when we're talking about moving our body, in particular in biomechanics, because it's where the greatest forces and movements occur, so the greatest degrees of change in range of motion occur around synovial joints. And so that's why we focus on them. Now there's some key features about synovial joints. One, you have two bones, but two, you notice they're not necessarily directly in contact with each other. Usually when we put weight or load them up, there is, but if there isn't any weight bearing going on, they're usually not in contact. And it's largely because instead of having a more solid gel in there, it's actually a fluid-filled sac. So it's this cavity of space held in place with this synovial membrane that's just full of fluid. So, you know, fluid, and it's meant to be slippy. It's like a lubricant, right? So we have these articular surfaces with cartilage, so the surface is smooth and glidey. But then we also have all this fluid inside the joint that adds to that extra lubrication and slidiness, okay? So really, really important. And the key feature about this is because there's so little built structurally within the joint to hold the two bones together. So here, again, directly connected together with a cartilaginous gel, directly held together with fibers. We have a bit more of an open joint here. And so with that open joint space, which happens in our fingers, our knees, our shoulder, they're all over our body, really increases the range of motion that those joints can perform. Okay, so that's key. With our synovial joints, of those ranges of motions that we can do, we have our uniaxial, so that means movement can occur in one plane. So remember, planes and directions are different. So one plane means, for example, forwards and backwards along that plane. If you remembered our coronal, putting on the crown, so our sideways plane, things that move along that plane can go, say, up or down. We'll get better descriptive terms for this, abduction, adduction, okay? But we also have biaxial, which means planes movement on two different planes. So a knuckle is a good one. So my fingers can go side to side or forward and backwards. Okay, so that's two planes. And then multi-axial or poly or triaxial is like your shoulder or hip or anything that can circumnavigate. So go in big circles, all sorts of different directions, and they can go through multiple planes. Okay. All right. This is a knee joint, by the way. If you wanted to just, I'll give you a brief overview. Patella. Here's the tendon and ligament that holds it in place. And this is a synovial joint as well. So there's joint fluid in here as well with all the cartilaginous articulations. So your knee would be an example of a uniaxial joint. However, there's been some research lately that states it might be biaxial, but it's very small. So generally you think of it as a uniaxial. Okay. That was the skeletal system and what you need to know. So again, joints are kind of the main one there, just to understand that there's certain limitations on how many degrees or different planes of movement that they can go on. Okay, so the muscular system, before we go forward, you can take a breather. Don't worry, you do not need to have all these muscles memorized. We generally, you need to know the muscle groups, and we'll go through, I believe we have an activity ahead of this, but essentially just, for example, you don't need to know the rectus, the vastus lateralis, and every single one of the quad muscles. You can just say the quadriceps. I think that'll be the level that we're learning things, okay, in this class. But the idea and the gist of this is, one, you can be familiar with a lot of these muscle groups, for example, the pecs, the lats, the delts. Like, being familiar with some of the more major muscle groups will definitely be beneficial for you. For the back, we won't go in huge detail. Most you might say the Erector Spine, which kind of cover all of them. The lats are back here. Maybe rhomboids would be spoken about. The glutes, hamstrings, and calves. Okay, that'd be about the degree that you need to know these in. But I think, in particular, when we get to later in the semester, it's definitely good to be familiar with how muscles work and how they generate force. Again, we'll talk about that a little bit later, but just so you can conceptualize a little bit in your minds when we're talking about the human body moving, I think it's really important to understand what's happening fundamentally at a muscular level. So we'll take a look at, if we were to zoom in to one of these muscles here, and we zoom in, and essentially, again, if you can kind of cover the bottom part and just look at this part up here right now, the muscle fiber itself. So our whole bulk of our muscles have multiple muscle fibers in there. So we have a whole bunch of cells. So you can think of like a holder at like a fast food joint with all the straws in there. Okay, and each straw is like a muscle fiber. It's a little big, but that's the idea. Okay, and then, as you can see in each straw, there's a whole bunch of smaller straws. So instead of the drink straws, now we have all those little coffee stir stick straws, okay? They're all folded up inside of there. And each one of those coffee stir sticks is called a sarcomere, okay? And so within one of those sarcomeres, what we have, and again, you don't have to know these names. I really should have blotted them out, but you can just do that in your mind now. But the really cool part about muscle physiology is right here. So this is after we zoom in. So we got the big holder, we got the drink straws, we got the coffee straws. So if you look inside the coffee straws, what we end up seeing are these filaments. And they're just strands of protein, but they do some pretty wild stuff, okay? So the thick filaments you can think of more or less as stationary and fixed, and the thin filaments you can think of as being on wheels and being able to slide. What ends up happening is when you have your thick and your thin filaments, and we'll just kind of look at half of what's going on here. When our muscles contract, the thin filaments kind of act as like a rower. So they row and they pull the thin filament closer in, okay? Now, when our muscles get long, so that's contracting and getting shorter, when they relax and get long, essentially the rower doesn't do anything. It just kind of like the thin filament, thick filament canoers essentially stop rowing. So they just kind of like pull the paddle out of the water a little bit, and allow the backsliding to happen. So then we return to a normal muscle length. So why is that important? Well, we kind of take a look here and come to understand that force production changes with muscle length. And again, we'll return to this later on, but the idea is if muscles are fully contracted and already shortened, that's, you can't get any more contracted than that. So you can't produce any force, right? This is the length here, this is tension or the amount of force it can produce. So it can produce very little force if it's already, like where else are you going to canoe to if you're already all the way in, right? And then same on the opposite end, if the canoes can't, or the thick filament canoes can't latch on to any thin filament, you're going to have a tough time generating any force. So that's what's happening down here. So you have this optimal range. And one of the practical things that you can take away from this and apply is this is exactly the reason why it is not suggested to static stretch before you start working out or before you start doing athletic performance, or even while you're doing it. The best time to do any sort of static stretching is when you're not going to be active. So the reason for that is if you want to be in this range of muscle length while you're performing or exercising, you need to be loose and warmed up but not stretched. And so what you do is you do a dynamic warm-up. You like move your arms, you swing your body, you do some very light activity to ease into your actual activity. Because if you static stretch, you end up putting your muscles into this position. And what people have tend to find, or research has found, is over time, if you're stretching a lot before you do your activities or during them, you actually end up getting poorer performance and higher risk of injury. Okay, because you go to produce a large amount of force or muscle tension, and you don't have the cross bridges or the canoe length to do it, and then you get injured. So something to keep in mind. Okay, so we got one more of these activities to go through. So hopefully, again, pause it, Google it. It's good to just pull up some anatomy charts and take a look and see where all of these are. Try to find them on your own. That's how you really ingrain knowledge and get a better working knowledge. So again, go ahead and pause now. And then we can come on back into it now. Okay, so again, I might have another second little video trying to demonstrate these a little bit better, but if not, we'll run through it quickly here. So here's biceps brachii, so that's your biceps right here. So bulk of your muscle here. Triceps are on the back, and if someone's quite lean, you can usually see like a little bit of like an upside down V where the triceps are. Pec major, well, that's here. Pec minor is a little less common and easier to find. It's about a 1.5 or 1 inch thick strip of muscle that runs from up here attached to your acromion or your collar clavicle, so your shoulder collarbone, and it'll run down to about the middle, and this is deeper than your pec major, to your rib cage and attach on 3 different ribs down there. Okay, so that's your pec minor. And the reason that's an important one is usually when we're working on our laptops, we're leaning forward all the time, we're on our cell phones, it pulls our shoulders forward and actually rounds out our upper back. And so a lot of people can get upper back pain from that, and or get shoulder problems because it holds their shoulders down and forward. So when they go to do stuff overhead, it really impinges back in the shoulder blade, and they can get some muscle issues going on with that too. So pec minor is a really important muscle for a lot of people in the general population, especially those that do a lot of computer work, and especially nowadays on laptops, to help get better posture and less pain that way. Okay, lats dorsi, well, they're a really big muscle. They cover most of your back, but they have a few parts that attach to your humerus all across your back, but you can usually see them out here on the side. If you hear people talking about bat wing muscles or getting a bit of a V shape to someone's body, usually that's the lats that are just under the arm on the rib cage that come out to the side there. Okay. Your trapezius, again, a huge back muscle. The upper part of your trapezius is here. It's the bulk on the neck muscle. You know, you see the very overly zealous bodybuilder guys in the gym doing lots of shoulder work, and they kind of get a bit of a no neck appearance, and that's from just having very large upper traps. Okay, but the trap also, or your trapezius, actually also goes through the middle part and down almost to the lower part of your back. Okay, or like lumbar spine. So it's this big diamond shaped muscle on your back. Okay, rhomboids, a little harder to find and palpate, but they're just between your shoulder blades. So if you can find the most medial borders of your scapula, your shoulder blades, the muscle is between part of your spine that sticks out and the edge of your clavicle, or scapula, sorry. Okay. Deltoids, well, that's the shoulder cap. That's this muscle. So some people think it's kind of up here, but it's actually, it goes all the way around back. And it kind of is like a wrapped around teardrop muscle that goes on your shoulder. Okay, it's right there. Yeah. Next up for the trunk, rectus abdominis. Well, that's your six-pack muscles. You can, those are from like forward crunch, sit up. Yeah, and that's those. But the external and internal obliques. So those are a little bit deeper. So the rectus abdominals are most superficial. And then the internal and external obliques, you can see on the side, they kind of cut into where the rectus abdominals are and then duck underneath. They actually wrap all the way around you. And the difference between them is your external obliques run this way, and then deeper to that, the internal obliques go this way. And so they help rotate the body. Again, anytime you think of 2 points on a muscle, when they contract, so if I have an angular muscle in my torso from here to here, and it contracts, it's going to rotate and crunch me forward. Okay. The erector spine, I pointed that out earlier, but it's like a big, I call it the double-sided bridge. So it's a big span of muscle that's just on either side of your spine. And usually in people's lower backs, you can see them. They're probably some of the muscles that get quite sore for a lot of people in their lumbar. But again, they're about an inch or an inch and a half wide that run all the way up the body and get thinner and thinner, all the way up to the base of the skull. Okay. Quadriceps, well, that's the front of the thighs, those muscles there, and you can kind of see closer to your knee if you stand and flex. They kind of have those, almost look like two bumps there. Hamstrings, that's the back of the thigh, okay, so the back of the upper leg. Gastrocnemius, that's a little maybe trickier to know. So that's your calf muscle, but it's just the top part. So it's the big, kind of upside down, heart-shaped muscle at the top of the calf, and that's made for producing power. So if you want some short, powerful bursts, say when we're jumping, definitely the gastrocnemius is the muscle that's involved in that. The second part, the lower part of your calf, the longer, skinnier part, that's called your soleus, and that's more used for like endurance-based activities. So if you're walking lots, or if you were maybe doing long jogs and stuff like that, that muscle would be more in use. Okay. Glute max, well, that's your butt, big glute muscles, and then glute med is just a little bit smaller. And again, it's kind of like the pec minor in that it's a strip that kind of is in the back of the glute and attaches from the top of the pelvis to the top of the femur. And when we squeeze that, it brings the leg back a bit and turns our foot out a little. But one of the most important parts about the glute med is if you're to stand up, and you can do this at home or wherever you're at, you can stand up on one foot, lift up your leg, and if you're to look in the mirror or just put your hands on your hips while you're doing that, if you notice that whatever leg you're standing on, the hip kind of kicks out a bit, that's potentially likely due to a weak glute med. So if everything is in line, so hip is in line with your shoulders, your knee, and your foot, probably means the glute medius is really activated, or you have a stronger one. Okay. Great, so that's all the musculature that you'll need to know. And again, this is pretty detailed, but again, just being able to see these muscles, be familiar with them, know generally where they are in the body and generally what they do. Okay. So we've covered our bases where we know our skeletal system. We've covered that. We know our muscular system. The whole point is that they work together, right? So our muscles are attached to our bones that work around the joints that cause movement to occur. We spoke a little bit previously about coordination systems. So like where on our body are we referring to as far as positionality? Now we're going to talk about movements, okay? So human movements. And again, these happen typically along one plane, and we'll show what they are. So here we have flexion, okay? So that means coming up and forward. So if I was to flex the arm, it'd be like that. And again, feel these out while we're going through these. Like actually give yourself a little room, actually do the movement, say it while you're doing it, and it just really helps ingrain everything, okay? So flexion at the knee pulls the shin back, okay? Forward flexion or flexion of the arm is up and forward. And then we have the opposite or the opposing motion, which is called extension. So the arm comes back, or if the shin is back at the knee, we have extension of the leg coming forward, okay? Very similar with the head. We can have extension and flexion, and we can have flexion and extension at the hips. Our whole body comes forward, our whole body goes back. Or, you know, if we were in the air, maybe performing some sort of a dive or something like that in swimming, we can actually forward flex our legs or extend our legs while in relative to our body. Or maybe we're doing leg extension exercises or whatever. So it is possible to do that. But a lot of the way that you speak when you're talking about these terms is you say flexion of, extension of. So, and the joint or the limb. So the knee, the leg extends back, flexes back at the knee. The head flexes at the neck, okay? So getting used to trying to get both where the action is occurring and the action is really useful. Okay, a few more, abduction and adduction. So this one, if you again think of that coronal plane, if my arm comes up and out to the sides as it's coming up overhead, that's abduction. Okay, so the way you can remember that, because it's kind of a funny word, is, you know, it's your classic movie scene, someone's walking along in the forest late at night, and all of a sudden there's a big spotlight that hits them. Oh no, terrible news, aliens, right? So spotlight hits them, and all of a sudden starts pulling their body up, right? And as they're doing that, what happens to their arms? Splays out to the sides, right? So it kind of comes up and out. So you can think of being abducted is the same as the limbs being abducted, okay? On the opposite direction, we have adduction. And so the way I remember this is I add the arm to my body. So if it's far away, I add it in. And again, that's all along the coronal plane. Circumduction is just circles. And there's very few places that can do it. Your shoulder can, your hip can to a degree, your thumb can to a degree, okay? So there's those. And then rotation. So with rotation, usually you say whether it's what sort of direction you're going in. So whenever we start in anatomical position, we always externally or laterally rotate, okay? We can also laterally flex, but if I'm off to the side, I can say I medially rotate to the middle. But usually you just kind of say laterally rotate, left or right rotation. And then here we go, lateral rotation, medial rotation at the hip. So that's a more apt way to describe that, okay? Great, and that's about it. So if we were to all pull that together, and again, this is really, really big at the end of the semester when we start talking about torques and forces and lever systems in and around joints. That's kind of where we pull everything together for the end of the semester. But you already have a bit of a working knowledge that our muscular system acts on our skeletal system around joints to cause movement, right? yeah, this is stuff we know, but now you have a little bit of a deeper understanding of that, okay? And as we'll come to find that these joint systems are like lever systems, and that's how we move. So again, hopefully that was maybe a refresher of some things for a lot of you, maybe a new first exposure to some of this information for others. But ultimately, again, a lot of this is just to be able to have a familiarization and a working knowledge and language, so that when we discuss things in class, we're all on the same page. Okay, well, good luck reviewing that material. I believe there should be something up on Blackboard for you as far as a way to work through these muscles and get a little bit more practice memorizing and working with the content there. It should be posted somewhere online under your course content. Okay, well, that was a great review, and hope you all enjoyed that. Bye.